Hey guys, am I audible visible? Let me know if so. I hope I'm audible and visible. Sorry for the post-prandial session. It was not working. My internet goofed up. Can you guys hear me? If you can hear me, if you can listen to me, say me a hi and a hello. How are you guys doing? So this is again a post-dinner session for a change. Like I said, I'll try to maintain the post-prandial thing. Today my net was not working, so I was not able to come up. Hello Chandu, hope you're doing good. Fine. So let's go with the second episode of Revised Pathology with Dr. Ranjith. Hello, good evening, Gayatri. Hello, Sham. Here we are going to see the MCQs with respect to intracellular accumulation, aging, and acute inflammation. I'll have 3 sessions of MCQ revision every day so that I want you guys to read it and let's revise. So this will be the first round of revision. After finishing this, we'll take chapter wise revision second round, and if time permits, we'll go to third round of general path, hemat, and systemic path. Right? Good evening, everyone. So let's start the routine. So tell me the answer and let's go and let's discuss something out surrounding it. The very simple thing, same methodology, one liner, one scenario based, so that we can cover almost everything required for us. Steven, Rachel, Navina, yeah, B, B, C. Okay, anyone else wants to add to it? What do you think will be the right answer? Please do comment. It's not a problem. If it's an error, it's an error. Ignore. That's all right. Okay, most of you have gone with B. Russell body is a characteristic accumulation of. We must have read about Russell body in case of a multiple myeloma. But yes, Russell body is like Chandu said and like Sham said, it's an intracellular immunoglobulin accumulation. It's actually seen in which cells? Which cells you can see Russell body? You see them in? Perfect. We see them in plasma cells. Right? Good evening, Archit. You see them in plasma cells. It's a classical accumulation of immunoglobulin seen in patients with multiple myeloma. So option B is the right answer. If immunoglobulin is not there, I am okay with the option protein as well, right? So protein is also fine because it's intracellular protein accumulation, as simple as that, fine. I want to cover a little bit in surrounding Russell body. Let's assume I don't have the option of immunoglobulin, neither I have the option of protein, right? Hello Roy, good evening. Okay, so I don't have both of the options. There might be one more thing which might signify Russell body, right? So there's a term called as hyaline. Okay, if neither protein nor immunoglobulin is there in the option, look for the third option, hyaline, right? Because hyaline literally means it's pink color in microscope. That's all. And protein, what will be the color of protein in a microscope in H&E? Obviously, it's going to be pink in color, right? So if it's not immunoglobulin, it's not protein, look for hyaline. That also is it's an intracellular hyaline accumulation. That's one of the classical examples for intracellular hyaline accumulation. Robbins mentions actually them under hyaline accumulations, right? Perfect. It's not lipoproteins, it's immunoglobulin, classical protein here, right? Like Chandu said, I do have an intranuclear inclusion, which is called as your Dutcher body, right? Okay, just let's go through a little bit about the basic rules of H&E. We have 3 colors in H&E: blue, pink, and clear. These are the 3 basic colors of your eosin and hematoxylin. What does blue indicate? When do you think you'll have blue color? Or which part of the cell will be blue in color? Which part of the cell? I'm sure you know the answer, right? Anything which has perfect DNA or an RNA will be blue in color. Just revisiting our basic things. Anything with nuclear content, DNA or an RNA, nucleic acid, will be bluish in color. That's the basic thing, right? The rest, everything in the cell will be pink in color. The cytoplasm, the protein, and anything else like glycogen, pinkish in color to clear appearance. Anything apart from your DNA, RNA will be pink in color. Again, this is our favorite thing, which is clear in appearance. Yes, you are right, Archit, as well as someone says Chandu as well. Which will be clear? Obviously, your fat. Fat will be clear, and also remember mucus. The mucin or mucus will also be clear in appearance. Lipid and mucus are something which are clear in appearance. These are basic thumb rules. Never ever forget till you practice medicine. Randomly you see a microscopic image. Still with this finding and a good amount of clinical knowledge, you can solve the microscope, right? Perfect. Now let's go to the second question. It looks big. Let's see. There's a trap here. So read the question carefully, slowly, and comment on the right answer. I'll keep quiet for some time. I want you guys to comment. 20 plus students watching. I want 20 plus answers here. It's okay. Let's make a mistake. Okay, Chandu has started with 1. So anyone else wants to change or add, what do you think will be the answer? Let's read through the question. It's a 50-year-old alcoholic presents with symptoms of liver disease and is found to have a mildly elevated liver enzymes. A liver biopsy is done. Routine H&E levels reveals abnormal clear spaces in the cytoplasm of most of the hepatocytes. So what's the diagnosis? It's a very simple diagnosis. First tell me the diagnosis. Let's go to the option later. It's perfect example of an fatty liver, right? Perfect. The classical example of a fatty liver, right? So now, obviously it's not calcium, obviously it's not hemocytin. Why didn't you guys opt for option B? Why is this not the right answer? Why it can't be cholesterol? It's steatosis, it's fatty liver. Option D is the right answer. I am not denying that at all. Triglycerides is the right answer. Why not cholesterol? Because cholesterol accumulation does not happen in the liver. So which means, can you give me any examples of cholesterol accumulation? It's steatosis. Steatosis purely by triglycerides and not cholesterol. Can you give any examples of cholesterol accumulation? Option D is the right answer, but B, any examples? I want you to remember at least 2 classical examples for cholesterol accumulation can come in an exam. One, obviously, is your xanthoma. I'll come to it. Gallbladder is one for sure. Xanthoma is one. Like perfect. Female said atherosclerosis. The first thing I want you to remember is atheroma. Because the coronary artery disease, because I can easily create a clinical question behind atheroma, like a chest ECG finding, a clinical scenario of chest pain, and a microscopy of the left ascending artery was taken. Atheroma, atherosclerosis. Second, yes, gallbladder. In gallbladder, we have a type of chronic cholecystitis, cholesterolosis. In that, I can have this. Again, just let's extrapolate. In case of a cholesterolosis of gallbladder, which layer of the gallbladder you will have cholesterol accumulation? It's actually a classical example. This particular layer will have lots of foamy macrophages laden with cholesterol. Which layer? The third one, like Achit said, obviously xanthoma also. I'm going to have lots of cholesterol accumulation, right? You will see in classically in lamina propria. So in the lamina propria of the gallbladder, you'll have lots of foamy macrophages filled with cholesterol. These 3 are examples for cholesterol accumulation, and like you said, steatosis is the classical example where you see triglycerides accumulation and not cholesterol accumulation, right? Okay, this is an example of fatty liver. These are all tiny fat deposits. All these are fat deposits, fine. Okay, again a very routine question which will be asked in Viva as well as in your exams. Why is fat clear in microscopy? Just a reasoning question, and I'm sure you know the answer. Reason fat is clear in microscopy is, it's simple, right? Because fat will be washed away during processing. They are washed away during processing, that's why it's clear in microscopy, right? The alcohol processing what we use will clearly remove the fat, that's why it's clear in microscopy, right? Perfect Miduna and Gayatri and Archit, fine. Okay, that's about fatty liver. Just one example of microvesicular steatosis. If you're in second year of MBBS, you might see them little bit later. We have micro and macrovesicular fatty liver. Tell me one example which I want you to remember with regards to microvesicular steatosis. Tiny vesicles. What is the example? One thing which comes to your mind. I want to think of drug-induced hepatitis. Please don't forget this. Whenever a question says microvesicular steatosis, at least with respect to an undergraduate, think of a drug-induced hepatitis and one particular drug, and I want you to comment on that. I'll give a classical history. A child after a history of fever took this medicine. After taking this medicine, the child had an hepatic failure. Very classical, you will see microvesicular steatosis in this child. What drug is that? It's one of the NSAIDs. And what syndrome is that? The drug is aspirin. What syndrome is that? I'm sure you must have read about aspirin-induced hepatotoxicity and Ray's syndrome, right? Because this is an important MCQ point. Ray's syndrome, classically you will see microvesicular steatosis, not just Ray's, any drug-induced. Like we have statins can cause drug-induced hepatitis. We'll also have microvesicular steatosis only. Just an extra additional point since we are in fatty liver, right? Amazing, guys. Okay. Again, a simple question. One simple, one difficult. What do you think is the answer? The simple one. I'm sure you know the mnemonic. I'll go the mnemonic or will go the logic. Anything. Catch it started with A. Samoma bodies. I hope all of you read this except. You didn't jump without reading the excerpt. That's the only twist here. Some of our bodies are typically situated in two tumors. One is papillary tumors. Anything with papillae, anything which is serous in the name will have some of our bodies, and your meningioma and leiomyoma will have some of our bodies, right? Okay. These are the classical ones with some of our bodies. If you want to go with the mnemonic, I am completely fine with it. Whatever makes you happy, that's your PSM square. Papillary, serous is there, right? In this PSM square, there is a stomatostatinoma. The only thing here is not all stomatostatinomas have samoma bodies. Only if they are from the duodenum. That's very, very classical. Only duodenal stomatostatinoma will have samoma bodies. And again, not all mesothelioma will have samoma bodies. Only your papillary mesothelioma will have samoma bodies, right? So if you're going with PSM square, little bit be specific. I don't want to get confused, right? Obviously medulloblastoma will not have samoma bodies. Meningioma, papillary carcinoma thyroid, and papillary serous adenocarcinoma will have samoma bodies, right? Okay, just one more extra pointer from here. Tell me what will be the microscopic appearance of medulloblastoma? Any one point, whatever comes to your mind. There's a clue in the name. It's medulloblastoma. What do you think will be the microscopic appearance? I'm sure you guys know. Medulloblastoma. I actually have two microscopic appearance. Fine if you're in the early part of your career, it's okay. You will have small round blue cells. That's one. Any blastemal tumor will have small round blue cells, and it has one rosette called as an. What's the rosette? Perfect. What rosette? What's the name of the rosette? Small round blue cells is right. What's the name of the rosette? Can anyone name the rosette? I have different types of rosette. This has a very classical rosette. We have flexner winter in your retinoblastoma. Here we have a classical rosette called an Homer right rosette. Okay, flexner winter seen in retinoblastoma in the eyes. Here we'll have classical Homer right rosette, right? Amazing, fine. Just an extrapolation. Whenever we read MCQ, we'll go tangentially to another part. Let's revise and come back to the normal again. Okay, next question. Might look difficult. Again, a very simple one. Maybe 3-liner and not a 1-liner. Let's see the right answer. Again, comment whatever comes to your mind. It need not be right. We have to comment. That's our routine. Okay, B. It's a light brown perinuclear pigment. That's my first important clue on H&E staining in the cardiac muscle fiber of an 83-year-old person, which means it's just a wear and tear pigment seen in patients with cellular aging. So cellular aging will have a pigment, that's your lipofuscin or lipochrome. That's completely fine. It's just a lipofuscin pigment. There are few other names for this pigment. We also call them a wear and tear pigment. It's a pigment of cells aging. Okay, it's a pigment seen secondary to atrophy. Anywhere there's an old protein, it's get destroyed, it accumulates. That's what is here. You'll have lipid peroxidation, and obviously it's increase in autophagy, it's increase in atrophy. It's a lipochrome pigment, as simple as that. Fine. There's an classical image of lipochrome pigment from Robbins. Nucleus. This is your pigment. It's getting a little bit blurred, so I'll zoom it out here. That's your paranuclear location. It's seen on the sides of the nucleus because the endoplasmic reticulum and the lysosomes is where all these gets accumulated, and lysosome is seen there, and so I'll have the pigment here. Fine. A classical normal finding. This pigment will not cause any disease. It's just a physiological finding seen in old age. That's all. Fine. Okay. A simple question again. This came once in an exam, and we'll have to look at any other options as well. Archit, like I said, for an undergraduate, it's just a physiological finding. Ignore it. But there are few diseases called as lipofuscinosis. If you're a postgraduate, that might be required. What's the right answer? The fixative used in histopathology. Okay, Kritika has gone with C, A, C, A, C. There's a fight between A, C, and B also came in Pravin. Okay, let's see. Okay, fine. So first we'll understand what does a fixative means, because this also came once in exam. The purpose of the fixative is to prevent autolysis. Can I say if I take anything from outside the body, the tissue will die? Obviously tissue will die. Fixative will prevent it. The easiest way to remember what is fixative is Once you went to your dissection hall in anatomy, you had a smell. What is the reason for the smell? In the dissection hall, all the anatomy, the cadavers will be stored in the embalming fluid, and the majority of the content of the embalming fluid is formaldehyde. Formaldehyde preserves. Formaldehyde will prevent autolysis. That's all. The same thing what you did in your anatomy, I'm going to use to preserve tissues in pathology also, right? 10% neutral buffer formalin is the most common used fixative. It will prevent autolysis and also it will reduce infection. Because I'm taking it outside the body, obviously there's a chance of infection. It can get infected, it prevents that. These are the two rules of fixative, and the most common done used fixative throughout the body is, throughout histopathology, is formalin, right? Buoyance was used in old days. We don't prefer buoyance these days, but if a question comes, testicular biopsies, buoyance were used, again not now, they were used. It's a little bit of a specific fixative or testicular biopsy, right? Someone already said glutaraldehyde. I have glutaraldehyde and one more guy, osmium tetroxide. A combination of glutaraldehyde and osmium tetroxide is used for which one? Where do you use glutaraldehyde plus osmium tetroxide? Use it for electron microscopy. If you want anything in electron to be visualized under electron microscopy, I have to fix them in glutaraldehyde and osmium tetroxide. This also came once in an exam. Can anyone tell me where is ethyl alcohol used as a fixative? It's used in a routine investigation, which is done for women as a screening test for cervical cancer. That's a clue. Where do you think you use ethyl alcohol? Perfect. 100% ethyl alcohol or 100% ethanol or an absolute ethyl alcohol is used in pap smear. For pap smears, fixatives and ethyl alcohol, right? There are 4 questions here. Whenever you see any questions, please don't superficially see the question alone. Try to read something surrounding that. So if we complete the options, I have 4 more new questions ready for us, right? Amazing, right? Great. Okay. Looks like a big question. Let's see how many of you can give the right answer. The simple one, read through it carefully and tell the answer. I'll read through the question. Okay, actually this started with C. An experimental analysis for enzyme activity associated with sustained cellular proliferation, right? Which of the following cells is most likely to have an highest telomerase activity? Telomerase is an enzyme which will not let the telomere shorten, right? That's what we already know. So telomerase actually is seen in quite a few cells. There are 3 options for me. Stem cells will have telomerase, right? Your germ cells will have telomerase, and also the pathological tumor cells. Tumor cells, there will be re-expression of telomerase. That's what happens in tumor cells, right? Of these, maximum quantity, even if all the 3 options are there, the maximum quantity is obviously in your germ cells, right? So germ cells is the right answer. This question is a bit simple. Endothelial cell, erythrocyte, neurons, all of them are not stem cell. They don't divide forever. So these cells actually don't have telomerase at all. It's a very simple one. Even if these 3 are then the options, stem, germ cell and tumor cell, the right answer, the maximum telomerase quantity is going to be obviously in your germ cells. That's what gives immortality to a germ cell, right? Perfect. Amazing. Okay. There's a tiny twist to this question. So choose the right answer. Choose the right answer in this question. There's a tiny twist. I'll tell you it soon. Yes, it's an RNA dependent DNA polymerase. Okay. People have gone with C. Kritika, Tanya, Chandu has gone with C. Okay, let's read through the question. I'll tell you what the twist is. A 11-year-old child falls and cuts his hand. The wound become infected and the bacteria extend to the extracellular matrix surrounding the capillaries. In this inflammatory response, which of these cells removes the bacteria? Fine. Okay, let's say I have 2 options in this questions. One, let's assume it's neutrophils. Second, let's assume it's macrophage. Now tell me which will be a more appropriate answer. What should be the more appropriate answer here? If one option is neutrophil, one option is macrophage. Can I say neutrophil will be a more appropriate answer? right? Because it's bacterial infection. Bacterial infection, by default, neutrophil will be a more appropriate answer, right? Please do remember, it's always in an exam, choose the best answer. It's not always the right answer, right? If neutrophil is there, obviously, like you guys said, I would prefer neutrophil. If neutrophil is not there in the option, don't say the question is wrong. Go with the second best option, that's all. Remember, you might encounter questions like this in your real exam, fine? B lymphocyte definitely will not help in removal of bacteria. Fibroblasts will not. Mast cells will not. The best answer here is macrophage, right? Good evening, Sonal. Okay, the macrophage is a better answer here compared to neutrophil. If I have neutrophil, obviously I'll go with neutrophil. So what actually happens in a real infection is, once you have a bacterial infection, the first guy who comes and removes is neutrophil. Neutrophil will have 24 hours. After 24 hours, all the neutrophil will be replaced automatically by macrophages. Macrophages will come inside, they will remove and they'll replace it. This is by routine even in an acute inflammation, right? There's only one disease, there's an exception. Okay? There's an exception here. There's there in Robbins, this came once in the exam as well. There's only one infection where neutrophils will not be replaced by macrophages. What infection is that? There's an infection where it will not be replaced by macrophage. I'll give you a clue for the infection. That infection also has a dubbed name called as blue pus, right? Archit is right. It is Pseudomonas. In Pseudomonas infection, neutrophil will never be replaced by macrophages. It will always be neutrophil. That's why if you go to microbiology, when you read microbiology, you'll read that Pseudomonas were also called as blue pus. It's always pus, right? Pus is predominantly your neutrophils. It will always be pus, purulent exudate, because in Pseudomonas, neutrophil will not be replaced. Macrophage will never come into Pseudomonas, right? Just remember this. If any exceptions are asked, they are all MCQ pointers, fine? Okay. Again, a simple question. Read through the options carefully and tell me the right answer. It's a simple one. I'm sure you guys know the right answer. Okay, Chandu started B, B, B. There are two types of calcification, right? I'm sure you guys know that. We have two major types, dystrophic and metastatic, right? How to remember which comes under what is very, very simple. Dystrophic means it's an abnormal tissue. That's all. So if a question says a pathological, a diseased organ is present, it has to be dystrophic calcification. By default, it has to be dystrophic calcification. Metastatic means it's an abnormal calcium metabolism. Here the organ is actually normal. Calcium metabolism is abnormal, so it is metastatic calcification. Of this, normal kidney can be metastatic. Fundus of stomach, normal, can be metastatic. Pulmonary veins, normal, can be metastatic. The only place which is abnormal is atheroma. Atheroma can have calcification, but they are dystrophic because they are damaged or dead tissue. I can definitely have calcification in any dead tissue for that matter, right? These are the only two differences I want you to remember always, right? Just an additional question. Tell me what will happen to serum calcium levels in case of dystrophic calcification. Normal, elevated, reduced. Serum calcium levels in case of dystrophic calcification. It will always be normal. Never forget this. It will always be normal, right? Serum calcium levels in case of metastatic, it will always be elevated, right? Elevated serum calcium is the main pathogenesis in case of metastatic calcification, right? Perfect. Amazing. Okay. Normal means a normal organ, normal serum calcium. There are two different things. Don't forget this. Dystrophic, metastatic, the name will help us to identify them, right? Perfect. Okay. Might look like a big question. Let's see. This is a final question and then we'll have few facts and one-liners after this. Tell me what's the answer. Prabin has gone with A. Anything else? It's not difficult. It might look big. These scenario-based questions, Robbins has a review book. If you guys want to practice more scenario-based questions, Robbins review book is an amazing source for practicing scenario-based questions. Okay, B, 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 B. B. Okay, let's read through the question. Actually, if you read through the question carefully, the answer is there in the last line. 5-year-old with history of recurrent bacterial infection, analysis of leukocytes collected from the peripheral blood shows deficiency of myeloperoxidase. So I already know the disease. It's an MPO deficiency. If you remember the acute inflammation respiratory burst pathway, where was MPO? The final step or the first step? Where was the MPO? The final step or the first step? If you remember your respiratory burst, which happened in your neutrophils after engulfing the bacteria, right? So you'll have oxygen, then you have your NADPH oxidase, then you had H2O2, then you had MPO with chlorine, then you had HOCl minus. So when MPO is gone, H2O2 will be formed. The final step, that is my HOCl, will not be formed, right? First step is NADPH oxidase, right? So the right answer here is hydrogen hydroxy halide radical, that is HOCl minus, will not be formed in case of an MPO deficiency. What will be the problem in this case? If it's option A is the right answer, what will be the disease? What do you think will be the disease? Which disease will have less H2O2 elaboration? It's simple, right? Wherever you have your NADPH oxidase defect, which is chronic granulomatous disease, right? So this will be your chronic granulomatous disease. When I don't have an NADPH oxidase, perfect. Chronic granulomatous disease will have that, right? Amazing. Super, right? Again, when you have a question, look at other 4 options. It might definitely give us some value, right? Let's go through few facts. Again, fastest finger first. Few facts and few one-liners, then call it a day. Okay. LAD1, LAD2. What's the inheritance? I'll ask you classical questions. I just want you to answer them. Few pointers which I want you to remember. LAD1, LAD2, inheritance. Both of them are autosomal recessive inheritance, right? Perfect. LAD1, what is the defect? Defect in? What is the defect in LAD1 and what is the defect in LAD2? Fastest finger first. You have to answer these things. LAD1, I have an integrin. See, both are leukocyte adhesion deficiencies. LAD1, I have a problem in your integrins. Perfectly beta 2 integrins, right? It's an integrin defect. What's the defect in LAD2? Yes, you're right. It's beta 2 integrin or just integrin superficially. LAD2, I have a defect in not selectin. I have a defect in sialyl Lewis X, right? I have a defect in sialyl Lewis X, not selective. Perfect. Okay. Both of these, tell me what will be the WBC count, reduced or elevated? Again, this is a unique finding for both LAD1 and LAD2. The WBC count, leukopenia or leukocytosis? You'll have, classically you'll have, great. Though they are immunodeficiency disorder, you will have leukocytosis, not leukopenia. It will be elevated because the cells are formed, they are not able to go outside. A classical finding here. Fine, perfect. Chidiac-Chiari syndrome, what is the gene mutation? Just few classical pointers and tell me one specific diagnostic point on microscopy and few classical clinical symptoms. Apart from your infection, I do have clinical symptoms as well, right? Perfect. The first thing is an LYST gene mutation. That's your lysosomal transporter. Amazing. What's a specific finding on microscopy? You'll have giant granules on microscopy, right? Classically, giant granules on microscopy, a classical finding seen in your Chidiac-Chiari syndrome. Yes, albinism is an additional finding along with your recurrent infections because they are migratory defect. Recurrent bacterial infection, obviously, ocular cutaneous albinism or albinism is another clinical information which you can see in patients with Chidiac-Chiari syndrome, right? Great. CGD, chronic granulomatous disease. Tell me the inheritance first and where you see the defect in. What's the inheritance of CGD? Inheritance of CGD. CGD has 2 inheritance. Do remember both autosomal recessive and X-linked recessive because there are 2 components of CGD, right? Both Akruti as well as Arumai, both are right, X-linked recessive as well as autosomal recessive. If it's X-linked residue, the membrane component of your enzyme, the defect is in NADPH oxidase, right? So if the membrane component of NADPH oxidase is defective, you'll have an X-linked residue inheritance, and if the cytoplasmic component is defective, I'll have an autosomal residue. It has dual inheritance. Do remember that, right? Perfect. Okay. Apart from the classical recurrent bacterial infection and everything, tell me one diagnostic test, a test to diagnose. One thing which has been historically been used. I do have enzyme analysis these days, but that test I still want you to know. The test is your NBT test. Nitro blue tetrasodium test. Yes, Fox gene is right. Nitro blue tetrasodium test. That's where you have this problem. Okay. We can pick up this diagnosis, but investigation of choice, I can use an enzyme analysis to identify that for sure. Right. Dihydrorhodamine can also be used. NBT, then enzyme analysis. I would prefer that. Fine. Okay. Just one question, tiny question for us to understand all these group of disorders little bit in detail. So if I take all these diseases, this is a primary problem in innate immune response or an adaptive immune response. Just answer that. Innate or adaptive? Because it might be required for us to understand how the patients will present. Innate or adaptive? LAD1, LAD2, Chidiakiyashi, your CGD or an MPO deficiency, all are innate immune response defect, right? Perfect. Now tell me, just answer this question. An innate immune response, are they more powerful or adaptive immune response is more powerful? Adaptive immune response is more powerful, right? So do you think these patients will have life-threatening disease or just recurrent like sore throat or recurrent URI? They might not have life-threatening disease. HIV AIDS is an adaptive immune response defect. It will be life-threatening. All these innate immune response defects will not be life-threatening because they are very subtle. I will have infections, URI, UTI, recurrent sore throat will be there, but it will not be life-threatening, right? So you might encounter them, but not be very much life-threatening. Please keep that in mind. But any disease in adaptive immune response will always be life-threatening because that's more powerful, that has long memory, and it's very, very specific, right? Okay. This just for an exam purpose, I have a type called an LAD3. I'm sure you must have read this. This has never come in any exam till now. Right? We are just hyping it up since we read LAD1 and 2. We are reading LAD3, right? It's kindled like 3 protein. That's the encoding thing. The 3 maybe you can remember for LAD3. Fine. Okay, perfect. Just few stains. I want you to just tell me the stains for each of them. Again, fastest finger first. What's the stain for hemosiderin? Stain for hemosiderin? You guys know the answer. Hemosiderin, at your pearls, Prussian blue. Next question. Do you think ferritin will be stained by pearls? Yes or no? Ferritin. Will pearls highlight it or no? No. Ferritin is pearls negative. Remember this. Ferritin, pearl stains only hemosiderin. It does not stain ferritin. Remember it. It's always negative. You don't need a stain for ferritin because ferritin is in duodenum. No one is going to assay the duodenal ferritin at any point of time. Pearl stains only hemosiderin. What's the stain for fat? Fat. As your Sudan black. Can be Sudan black B, Sudan black 3, 4, many things are there. And you have your, I don't want the ferritin stain at all, right? Just remember hemosiderin, that's more than enough. Okay, I'll tell you why I don't want ferritin stain. And oil red O. Because there's no disease where ferritin stain is required. Ferritin is a physiological storage form of iron. It's in duodenum. Do we even worry about duodenal ferritin? When I have an iron deficiency anemia, you take duodenal ferritin or serum ferritin? I take serum ferritin. As an acute phase reactant, am I worried about duodenal ferritin or serum ferritin? I'm worried about serum ferritin. Serum is blood. I can assay it, I cannot stain it. Right? That's why I don't want you to remember that at all. It's a redundant thing. Don't even remember that. Only one stain for iron. That's pathological stain. Pearl Prussian blue. That's enough. Right? Stain for melanin. Melanin has a Masson Fontana. Okay? Masson Fontana is a stain for melanin. If required, remember again, melanin can be easily picked up on a light microscopy. You can easily pick up melanin. Unless it is difficult, you want to prove it's not melanin, you can use Masson Fontana. Fine. What's the stain for copper? Copper has multiple stains. Copper has Arsine can be a stain for copper. Your rhodamine can be stained for copper, rhodamine or rhodonine, or your rubionic acid. Okay, there are multiple stains for copper. My personal preference is Arsine. Again, I don't know what is the examiner's personal preference. You can go with whatever it is: rhodonine, rubionic acid, or your Arsine. Anything can be a stain useful for copper. Fine. Any stain you remember for protein and glycogen? Both are PAS positive. I just want you to comment which is diastase sensitive, protein or glycogen. Which you think is diastase sensitive? Diastase sensitive, protein or glycogen? Diastase is an enzyme which digests glycogen, and glycogen is diastase sensitive, right? Protein is diastase resistant, because like I said, diastase is an saccharidase. It can destroy glycogen, it cannot destroy protein, so it's resistant to diastase digestion, and this is sensitive to digestion. Amazing. Can anyone tell me one commonly used stain for calcium? I'm sure you know two stains. If you want, comment both the stains, but at least one stain which I want you to remember, which is 1-cosa. 1-cosa is stain for calcium, which is the commonly used one. I do have one more stain called an alizarin red, not often used, but alizarin red is a superior stain to 1-cosa, but 1-cosa is the commonly used stain. That's the only stain available in the labs, to be specific, right? Okay, perfect, amazing, right? So these are few one-liners. So we're done with the first chapter. I hope you've fight ferrocos is staying useful for your microbacterium leprae, right? Okay, so I hope you were with me. Please read the topics. Next class, whenever it's there, I'll put up in the group, in the WhatsApp group, and I'll share this PDF also in the WhatsApp channel. I'm trying to move away from Telegram. Too much of spam. WhatsApp is a little bit more personal. No one will be able to see your number, name, nothing. It's a channel. I'll just post the content there, and let's learn more together. Fine. So thank you for your time. See you soon. Bye bye. If there are any doubts, do ping me on Insta. That's much more comfortable for me. Okay? Thank you. Bye bye.